Okay, yeah, my paper is Review of Maternal Mortality and Near-Miss Events in Kintampo Municipality in the Brong Ahafo region of Ghana by Gabriel Opoku. Introduction. Maternal death is defined as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to aggressive by pregnancy, its management, but not from accidental causes. WHO 1993. Maternal near-miss events is defined as any pregnant or recently delivered woman within 6 weeks after termination of the pregnancy or childbirth who experience complications that immediately threaten or survival but did not lead to her death because of decisive timely intervention. Such women arrive at the hospital or clinic in critical condition or develop critical complications after admission. According to the international estimate published in 2012, 2,087 maternal deaths occur annually worldwide, which represent 47 decline from levels in 1990. However, 99 of these still occur in developing countries, with 88 occurring in Sub-Saharan Africa and South Asia. Among developing nations, Sub-Saharan Africa has the highest maternal mortality ratio, with 500 maternal deaths and 1,000 live births, in comparison to global of 2010. In addition, for every woman who dies, approximately 20 more present infection, injuries, and other things. Problem statement. Ghana has numerous initiatives in place to address the issue of maternal mortality, but the results have not led to desirable improvement in Millennium Development Goal Target 5. Specific initiatives put in place to address the high level of maternal mortality death include the Safe Motherhood Initiative, Ghana Vitamin A Supplementation Trial, Survival Program, Prevention of Maternal Mortality Program, Making Pregnancy Safer Initiative, Prevention and Management of Safe Abortion Program, Intermittent Preventive Treated Network of Malaria, Maternal Neonatal Health Programs, Rollback Malaria Programs, and the free antenatal care. Despite the effort made to reduce maternal mortality, it remains high in Ghana, and the Brong Ahafo region is of no exception. In 2007, Brong Ahafo region recorded 88 maternal deaths. However, in 2008, maternal deaths in Brong Ahafo region reduced from 88 to 81. In 2009, maternal deaths in the Brong Ahafo region increased from 81 in 2008 to 94, according to the opening report of the annual review meeting of the Regional Health Directorate at Fiapre, near Sunyani on the Brong on the February 18th. 2010 again, the Regional Health Directorate of the Ghana Health Service recorded 76 cases of maternal death in 2011 as against 66 cases previous years. Looking at this status from 2007 to 2011, Brong Ahafo region alone has experienced 405 maternal deaths, of which Kintampo experienced 30. In 2007, Kintampo Municipality experienced 2 maternal deaths, and in 2008, the figure increased to 8. Maternal mortality was 6 in 2009. In 2010, the municipality experienced 10 maternal deaths out of the total of 66 of the entire region. In 2011, Kintampo Municipality recorded 4 maternal deaths. The increase in maternal death and near miss in the region substantiates to the need for this research to be done to find out the factors contributing to maternal mortality and morbidity in Brong Ahafo region, using Kintampo Municipality as a case study. Main objective of the study. The main objective is to review maternal death and near miss events at the Kintampo and facility level of Kintampo Municipality of the Brong Ahafo region. Specific objectives: to determine factors that influence utilization of antenatal care service, to determine factors that influence utilization of family planning, to ascertain factors that influence women to opt for abortion, to determine how delivery care influences maternal deaths, to determine factors that influence postnatal care services, to determine how education and information services influence maternal death, to determine how delay in reaching health facility influence maternal mortality and near-miss events. Methodology. Study type. A non-experimental descriptive design utilizing maternal death and near-miss event was used for data correction to determine factors contributing to maternal mortality and near-miss event in Kintampo North Municipality in the Brong Ahafo region of Ghana. Study area. The study area comprised all the sub-districts in Kintampo North Municipality. Sample size. The study participants were 196. Data correction technique. Secondary data was used to correct information at facility level, of which 16 health staff took part. In all, 30 maternal deaths and 45 near miss from 2007 to 2011 were reviewed. Verbal autopsy was used on 180 participants from 5 communities. Chi-square was used to analyze the results and discussion. Age has been noted to be a significant factor in the incidence of maternal death and morbidity. Christian 2009. Indeed, most of the maternal deaths and morbidity occurred among relatively younger women. The study found out that 6.67% of the women who experienced maternal mortality and morbidity were adolescents, 69 were young adults, and only 1.33 was middle adults. Prolonged labor or obstetric labor occurs when malnutrition is greater and where girls married at young age are expected to prove their fertility. The consequence of maternal mortality and morbidity and mortality, National Research Council 2009. Maternal deaths and morbidity among married women was 77.3% as compared to single women 22.7% respectively. This may be due to the fact that this may be due to the fact that women are not respond to in fact, out of 75 women who experienced maternal mortality and morbidity from 2007 to 2020, 49 basic education, 32 had basic education, and only 6 had education up to second level. The computer chi-square is 22.166 and significant value is 0. Therefore, the study found out that the level of education and maternal death are not independent. The occupation, therefore, are not independent. Therefore, the study found out that the level of education and maternal death are not independent. The occupation of the woman was also a significant predictor of maternal deaths and near-miss events. The study found out that 10.7% of the women were unemployed. 40% were in small-scale farming. 32% were petty traders, and 17.3% were in appreciates in the seamstress and hairdressing. In fact, there was no death and near-miss event in civil, public, or servants. It is presumed that the pregnant women who were employed were more capable, concerned, and responsible for themselves, either than relying on their husband as compared to those unemployed. The obtained chi-square statistics has a value of 16.155 and its significant value is 1.2. Majority of the women who died as a result of pregnancy or age-related complications did not use ANC services. This was observed in many studies. Who used the services fell below the national average about 90%. It was also observed in the study that 37 mothers who experienced complications after delivery, 16.2 had the PNC less than 3 days after delivery, 29.7 3 days and above, 54.1 had no PNC. Of the women who did not have any PNC, 70% of them died. Serious complications can still occur after the woman has given birth, and as such, activities carried out during PNC include management of the normal pregnancy, identification and management of complications. The study revealed that majority, 69.3% of the women who experienced maternal death and morbidity received care from auxiliary midwives and TBAs. Sri Lanka National Healthcare System expansion and improved midwifery skills contributed to dramatic decline in the maternal mortality rate. It was observed in the study that majority, 69.3% of women experienced maternal death and morbidity were not cared by a facility with necessary emergency obstetric care and equipment. For maternal mortality cases, 73 were delayed in reaching health facility, and reason was distance to nearest health facility was too far. Indeed, majority, 96.7% of the death occurred in health facility. The majority of women experienced maternal mortality and near-miss event. 74% were in critical condition upon arriving at the hospital, suggesting that important delays were encountered reaching the facility. The study found out that 72% of mothers who experienced maternal mortality and near-miss event did not receive adequate care during pregnancy, delivery, and after delivery. The director of Nengushi Institute for Medical Research, Professor Ofori Eji, speaking at the launching of the initiative of maternal mortality program assessment in Accra on Wednesday, 6 February 2003. Conclusion. Most of the maternal death and morbidity occurred among young adults within age of 20 to 30, with mean age of 27. Risk of maternal death was where and mortality is less among unmarried women than married women. Women who are not educated stand the risk of maternal death and those who are educated. Pregnant women who are unemployed are more likely to die than those who have occupation or employed. Women with more parity are at risk of experiencing maternal death and morbidity. More women die during delivery and after delivery in the district. Majority use ANC services less than 4 times as required. Majority complain about unfriendly attitude of health staff during ANC. Many of the pregnant women in the municipality develop complications. The complication arises because of delayed facility. Majority of the women distance to nearest facility was 7 kilometers and above. The contributory factor to the delay were distance to nearest facility and home management. Various modes of transport were used, including walking, taxi, and market trucks. Most of them delayed in reaching health facilities suffered complications. Among complications experienced were excessive bleeding and severe anemia, eclampsia, and sepsis. Most of the women delivered in the health facility. Women who did not deliver in the health facility were assisted by TBs at home, with more majority of them are trained. Majority of women who did not deliver at health facility attributed their failure to do so because of the unfriendly attitude of health staff. Women who delivered at home have risk of dying as compared to those who delivered at health facility. Risk of experiencing stillbirth in women who delivered at home is higher than those who delivered in the health facility. Most of the mothers did not use PNC services. Attitude of health staff and financial constraints were the contributing factors that discouraged the use of PNC services. Most of the facilities do not have necessary emergency obstetric equipment for health services. Indeed, clients are stabilized before referring to Kintampo Health Facility Hospital. Majority of the women did not have adequate monitoring during pregnancy, delivery, and after delivery. Most of the health facilities do not have blood banks, and even a few of them always experience shortage. Majority of the women who experience maternal mortality and did not receive much education and information services during pregnancy and delivery and after delivery. Way forward, policymakers and providers must re-examine current approaches to improve reproductive health, addressing the contextual factors and community-based issues, uncovering and unveiling the barriers to seeking care embedded in the context of this study could be beginning step to address reducing maternal mortality and mortality. District Health Directorate, in collaboration with districts who are in the remote areas, whose pregnancies are few weeks or months to gestational term. If this is done, it will avoid unnecessary delay. It is necessary to increase the beds in medical facilities with trained attendants. Training skilled attendants who are able to prevent, detect, and manage obstetric complications as well as providing equipment during other supplies is the single most important factor preventing maternal death. Municipal health district teams should assist in the development of the program and policies that reduce unsafe abortion and improve access to safe abortion and high quality prenatal care. References: Period of Mind 1994, Distance from Healthcare Quality of Care, expected to health center and ability to pay for service also can affect disease to make decisions. United Nations 2009 Million Development Group 5 Annual Report. WHO World Health Organization 2006 Annual Report. WHO Statistics 2010 Report. United Nations Millennium Development Group 5 Annual Report. Thank you very much. I'm done.